So as I had already mentioned in this class, once upon a time, I wanted to be a neurologist, right? I really think that neurology is super fascinating. I think it's one of the most interesting fields in medicine. There's a lot to it, especially like the mood components. And then I realized quickly that's what I was more interested in was the mood disorders. The mood disorders, schizophrenia, bipolar, psychiatry. That was mostly what I was interested in. I wasn't so much interested in the actual neurology component, despite it being fascinating. But clinically speaking, neurology is extremely depressing. You're dealing with stroke patients, you're dealing with cerebral palsy, you're dealing with patients that have had neurosurgery. I had a supervisor of mine, he was a PGY3 resident in internal medicine. He was from India. When he was living in India, he was a neurosurgeon. And I'm like, dude, why did you move to the United States to do your residency here? You were like a neurosurgeon. That's an amazing position. And he's like, yeah, I was like top, I was like on the top of the totem pole as a neurosurgeon. But he said that he couldn't deal with the patient outcome. He said most of the patients that would come out of neurosurgery would be in a vegetated state or they would have severe neurological deficits. And so for him, he found it very depressing as well. So it takes a certain type of person to be a neurologist because you are going to be dealing with some pretty bleak stuff. But regardless, it's all very, very interesting. So we're going to talk a lot about strokes, the outcomes of strokes. We're going to talk a little bit about seizures, the different types of seizures. We're going to talk about the different types of headaches. We're going to talk about also inflammation due to infection, so meningitis versus encephalitis. We're going to talk about dementia later on. We're going to talk about other progressive disorders like ALS. And then we're going to get into the psychiatric component. And I think it's kind of unfortunate that for this class, the psychiatric component is like this much. It's really not that much. I think psychiatry is so fascinating, and it is way more than just depression, schizophrenia, and anxiety disorders. There's all sorts of cool, interesting conditions. But I guess you have to take a psychology course on campus if you want to learn about all that stuff that's in the DSM-5. But cool. So let's talk about strokes. Anyone here like the Strokes? Yeah, great band. Anyways, so strokes or cerebral vascular disease, cerebral vascular accidents. And so the main causes are going to be either ischemic or hemorrhagic. TIA is transient ischemia, and a transient ischemic attack, it looks like a mini stroke. So you get the symptoms of a stroke, but it goes away, right? So it's transient. It happens very briefly. Ischemic strokes are going to be the most common. Ischemia is going to be due to emboli, right? Thrombus or an embolus. Or if you have shock, right? If you're in cardiogenic shock and you have reduced cardiac output, you're not going to get blood to your brain. So that's also going to be an ischemic type stroke as well. Versus a hemorrhagic stroke, that's where you have a vessel bursting and now you have blood just spewing everywhere in your skull, right? And so you're hemorrhaging, you're losing blood. You can see that from dissected aneurysms, subarachnoid hemorrhages. What's the most common cause of subarachnoid hemorrhages? Like berry aneurysms, right? Yeah, ruptured berry aneurysms. And then TIAs, again, those are going to be very short-lived. So let's watch a little video on ischemic strokes.
When someone is having a stroke, every minute counts. Just as putting out a fire quickly can stop it from spreading, treating a stroke quickly can reduce damage to the brain. If you learn how to recognize the telltale signs of a stroke, you can act quickly and save a life, maybe even your own. For both men and women, look for these 5 signs of a stroke, all of which come on suddenly. 1. Numbness or weakness in the face, arm, or leg, especially when felt on just one side of the body. 2. Confusion, including trouble speaking or understanding speech. 3. Trouble seeing from one or both eyes. 4. Trouble walking or problems with balance or dizziness. 5. Headache, especially a severe one that comes on suddenly. The clock begins ticking as soon as you spot the signs of a stroke, because some treatment treatments can only be used if the patient reaches the hospital in the first 3 hours after symptoms appear. So don't wait. Call 911 right away and get the person to a hospital immediately, even if the symptoms go away. If you think someone is having a stroke, remember the word fast. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. Finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast. Strokes are medical emergencies. The sooner a patient gets treated, the better their chance of a good recovery.
All right. Cool. So hemorrhagic stroke.
During a hemorrhagic stroke, abnormal bleeding disrupts normal blood flow. For example, in an intracerebral hemorrhagic stroke, a blood vessel bursts, spilling blood directly onto your brain while robbing the intended tissue of nourishment. Both the hemorrhage and lack of blood supply, called ischemia, destroy brain tissue. A subarachnoid hemorrhagic stroke occurs when a weak spot in a blood vessel wall, called an aneurysm, bursts, leaks blood into the tight space between your brain and your skull. The high pressure bleeding results in serious damage to brain tissue. Immediate treatment for your stroke may help to minimize brain cell injury and death in the case of hemorrhagic stroke. Emergency surgery may be necessary to repair damaged arteries or reduce the pressure of the blood on your brain. You may be given medication to help the brain's blood flow return to normal.
All right, so treatment for strokes are going to be different depending on what type of stroke it is as well. So if you have an ischemic stroke, the way it gets a little complicated with timing. So if it's within 3 hours, you can give the person a clot buster, so TPA, so tissue plasminogen activator. So that's within 3 hours. If it's beyond 3 hours, it's up to the discretion of the neurosurgeon or neurologist whether or not they want to take the risk of giving them TPA. Because after 3 hours, technically speaking, you have so much death in the brain that those vessels can now become compromised, and then it could turn into a hemorrhagic stroke as well. So that's why it's concerning if you give TPA to a person who now develops a hemorrhagic stroke. That means they're going to bleed out very rapidly. Versus a hemorrhagic stroke, you do not want to give that patient TPA ever, because that's going to further the bleed and it's going to rapidly cause death on that patient. And then we'll talk about some treatments a little bit later, but let's look at a little TIA video here, transient ischemic attack.
Particularly on left side, on the left side. Doctor said to breathe in, breathe out, manage stress. I'm trying. I don't know why it's happening to me. It happened this morning again. When I got to the hospital Monday night at 12:30 in the morning. Now I'm taking the picture for an example of what happens. 43. And it's hard to lift up. Touch something. My nose.
and that should eventually resolve on its own. Those patients are a very high risk of developing a full-blown stroke later on. Okay, so it's a huge risk factor for an actual stroke when you have TIAs. Risk factors, basically all the same stuff that we talked about in cardio, right? So hypertension, diabetes, hyperlipidemia, congestive heart failure as well, AFib. Why AFib? Because of thrombus and emboli, thromboemboli. That's what happened with my dad. He has AFib, and that's how he had his stroke last year. Pneumonia can also predispose a person to getting stroke. And then atrial venous malformations, which we'll see in a second. So let me show you a little video of signs and symptoms. So we saw that lady with the TIA. Oh, that's the wrong one. Sorry. So for stroke, a really good video to see is for the libertarians in this room. We got a video of Ron Paul having a stroke on national television. Yeah, so let's watch that again. So this is on national television when Ron Paul was running for president. So you see, that's an aphasia that he was developing. Aphasia means difficulty speaking. And there's different types of aphasias, and we're going to talk about them in more detail in a second. So that was Ron Paul. He's doing better now. So, you can get treated for stroke, and you can recover depending on how fast you get treated. Ron Paul's a doctor, so, he probably knew what was going on, and probably same with those around him. His son also is a doctor too, so. Anyways, so those are what strokes look like. You get difficulty talking, so aphasias. You might have impaired vision or memory. For my dad, he had an occipital lobe stroke. So it was in the back of his head, right? So the occipital lobe, that's where you have visual processing. He was having these crazy hallucinations. Like he was just seeing all sorts of weird stuff. He still has hallucinations now, but it's not as bad as when he was having an ongoing stroke. Like he was walking around in the middle of the night, just like seeing stuff and like just trying to talk to the people at the group home. And I thought he had a UTI. I was like, go take him to the hospital for a UTI. And then that's when they figured out, it's not a UTI. It's actually neurological. It's actually a stroke. So he's doing better now, sort of. Headache, paresthesias, paralysis. Depending on what part of the brain is affected, you'll often see contralateral, so the opposite side. Remember that lady? She was having droopiness on the face, right? So you'll see droopiness on the contralateral side. You'll see also paresthesia and paralysis on the contralateral side. So if you want to test it, you can take the person to a CT scan right away. CT scan is going to be one of the first things you want to do so that you can see if it's either ischemic or it's hemorrhagic. And depending on what it is, that's going to help determine what the treatment's going to look like. If it's ischemic, you want to give them a clot buster. If it's within 3 hours, give them TPA. If it's hemorrhagic, you want to try to stop the bleed and fix whatever is going on. You can also do a carotid ultrasound because that might tell you if it was like a thrombus, not a thrombus, but if you had a little clot that threw off of the arthrosclerosis that might have caused an embolus. And then, of course, the treatment is going to depend on what kind of stroke you're seeing.
Every 2 seconds, someone somewhere in the world experiences a stroke, and 1 out of every 6 people will have one at some point in their lives. Strokes deprive brain cells of oxygen and are one of the most common causes of death and a leading cause of preventable disability. When someone experiences a stroke, quick medical care is critical and can often help avoid permanent brain damage. But what causes strokes in the first place, and what can doctors do to treat them? The brain makes up just 2% of your body's mass, but consumes more than 20% of the oxygen in your blood. That oxygen is carried to the brain through a system of arteries. Carotid arteries supply the front of the brain, and vertebral arteries supply the back. These are connected to each other and divide into smaller and smaller vessels that get billions of neurons the oxygen they need. If the blood flow is interrupted, oxygen delivery stops and brain cells die. There are two ways this can happen. Hemorrhagic strokes are when a perforated vessel allows blood to leak out. But the more common type is the ischemic stroke, when a clot blocks a vessel and brings blood flow to a halt. Where do these clots come from? On rare occasions, a sudden change in heart rhythm prevents the upper chambers of the heart from contracting normally. This slows down blood flow, allowing platelets, clotting factors, and fibrin to stick together. The clot can be carried up towards the arteries and blood vessels supplying the brain, until it gets to one it can't squeeze through. This is called an embolism, and it cuts off the oxygen supply to all the cells downstream. The brain doesn't have pain receptors, so you can't feel the blockage itself. But oxygen deprivation slows brain function and can have sudden, noticeable effects. For example, if the affected area is responsible for speech, an individual's words may be slurred. If the stroke affects a part of the brain that controls muscle movement, it can cause weakness, often just on one side of the body. When this happens, the body will immediately try to compensate by diverting blood flow to the affected area, but this isn't a perfect solution. Eventually, the oxygen-deprived cells will start to die, leading to brain damage that may be severe or permanent. That's why it's important to get medical care as fast as possible. The first line of treatment is an intravenous medication called tissue plasminogen activator, which can break up the blood clot and allow blood to flow again in the compromised artery. If it's delivered within a few hours, this medication greatly increases the chance of surviving the stroke and avoiding permanent consequences. If tissue plasminogen activator cannot be given because the patient is on certain medications, has history of major bleeding, or the clot is particularly large, doctors can perform a procedure called an endovascular thrombectomy. Using a fluorescent dye that illuminates the blood vessels under a strong X-ray, the physician inserts a long, thin, flexible tube called a catheter into an artery in the leg and maneuvers it all the way to the blockage. A retriever is passed through this catheter. It expands and anchors into the clot when it's just past it. The catheter then pulls the clot out when it's removed. These treatments need to be delivered as soon as possible to preserve brain function, which means figuring out fast if someone is having a stroke. So how can you tell? Here are 3 quick things to try. 1. Ask the person to smile. A crooked mouth or facial drooping can indicate muscle weakness. 2. Ask them to raise their arms. If one drifts downward, that arm weakness is also a sign of a stroke. 3. Ask them to repeat a simple word or phrase. If their speech sounds slurred or strange, it could mean that the language area of their brain is oxygen deprived. This is sometimes called the FAST test, and the T stands for time. If you see any of those signs, call emergency services right away. Lives may depend on it. We're on a nonprofit mission to revolutionize education. Click here to learn how you can get involved.
So, yeah, those little surgeries where they can remove the clots are so freaking cool. Like, and some people get stroke and severe strokes. They'll go in and they'll actually remove that clot, and the person will completely return back to normal. Right? No permanent damage. It really does. It depends on how long the ischemia is, because time really does matter when it comes to the proper treatment of a stroke. Atriovenous malformations are going to be these really crappy vessels. And when you have these really badly made vessels, those are going to be an increased risk for hemorrhagic stroke. These are going to easily bust. Right? So they're really poorly made vessels. And here is the mnemonic for stroke, right? So you can do speech, tingling, remembering, off balance, killer headache, and eyes. Honestly, you don't really need mnemonics to remember anything about it when it has to do with a stroke, because it's going to be pretty obvious what's going on, right? The patient's going to have drooping of their face. They're going to have paralysis, perhaps. Maybe they have paresthesia. They're going to have difficulty talking, right? They might have numbness and tingling, things like that. So those are all going to be things that you'll see with stroke. These are all the risk factors. Again, same risk factors for heart attack, right? Exactly the same type of stuff. Now, let's look at some of the tests that you could do, and then we're going to talk about, you know what? Yeah, let's finish up with this first. So if you were to do a test on a patient, there's a couple different types of drift tests that you can do, but you could do a pronator drift, where you have the person hold their hands out, right? So the reason I have, little baby Yoda over here holding his bowl of soup, that's supine, right? So when your hands are pointing towards the ceiling, it's like you're holding a bowl of soup. That's supine. Pronated is when your palms are facing down, when surfaces are facing down to the ground. So if you have pronator drift, that's where you have them hold their hands out, have them close their eyes, and then you start seeing one of their arms drift off to the side. Right, that would be pronator drift. And that could be indicative of a upper motor neuron lesion of some sort. It could involve the corticospinal tract as well. And it's going to be, generally speaking, on the opposite. So if it's on the left side, you're going to see right-sided pronator drift. Okay, left side of the, if it was on the right side of the brain, it would be left-sided pronator drift. Let's watch a short video before we leave.
Palms up, and still close your eyes. The brain has a drifting information, which none should have a pronator drift to do it, and all starts with this.
Yeah, so another thing that you want to do too with those types of patients when you're doing that physical exam, like usually you have them close their eyes. You can have them seated. That's probably the safest way. But if you have them standing and doing it, you can also check to see if they have like cerebellum damage. Right? Cerebellum is responsible for like maintaining posture. And if you have them close their eyes and then they all of a sudden don't know where, because of proprioception, they don't know where their appendages are. Sometimes they can actually get kind of dizzy and fall over. So you want to stand behind them and make sure that they're not going to tip over and fall when you're doing this type of test on the patient. But again, for pronator drift, you can just have them seated, just like in that video. All right, so next time we meet, we're going to be talking about the arteries that are involved. We're going to be talking about different regions of the brain that might be involved and the different types of aphasias. And that's where we're going to continue on Friday. Do we have any questions? Cool. All right. Have a great day, guys. I'll see you on Friday. All right, y'all. How's everyone doing today? Is doing good? Cool. So we're going to continue on from where we left off last time. So last time when we were talking about strokes, we were talking about like upper motor neuron lesions. We talked about some tests that you could run for those types of patients. And so one thing you could do is have the patient do a pronator test. So I just want to recap on that because I had some folks asking like what this is all about. This is just a test that you do in clinic just to see if you have any sort of neurological deficits. It can indicate upper motor neuron lesions, cortical spinal tract. There's also other types of drifts that can demonstrate cerebellar type damage. And recall from your basic anatomy that the cerebellum is going to be associated with posture, your gait, or how you walk. So if somebody has damage to the cerebellum, they might have unsteady gait. They might also have deficiencies in proprioception. Do you guys know what proprioception means? Yeah, so it's knowing where your limbs are in three-dimensional space. Right? So if I close my eyes, I know my arm is kind of behind me on the right side, right? I know where my arm is. If I had a lesion in my brain that would impair proprioception, I wouldn't know where my arm was. So that's kind of the idea with doing the pronator drift. You have the patient close their eyes, and they hold their hands out supine, right, with the surfaces facing the ceiling. They close their eyes, and then they don't know where their arms are, because they might have damage in proprioception, and all of a sudden their arm might start drifting off to one side. And so it becomes more pronated and it starts drifting off. That's why it's called pronator drift. And if the person is standing up while you do that test, you want to make sure that they don't fall over. You want to stand behind them while they do that, just to make sure that they're steady. Because if you have problems in proprioception, you're also going to have problems with balance too. You're going to have a high likelihood of being able to get disoriented when you close your eyes. You're not going to see where your body is in three-dimensional space, so you can easily just topple right over. So that's not the case when they open their eyes. When they open their eyes, they're able to see what's going on, right? So they're able to orient their hands. They're able to make sure that they maintain a good posture when they're the eyes open. So let me just play that video again. I know we closed off with this last time, but it's worth watching again. With this patient, this mock patient, they had the person seated. So that would be a good way to do it too, is so they don't fall over. Okay. Things you can also do while the person is, got some Key and Peele. Things you can also do when the person is holding their hands out, you can also kind of like push their hands down to see if their hands go back up to where they originally are. And then another test you could do too, you could do the finger to nose test. So you hold out your finger and you tell the patient to touch their nose and then touch your finger. And so if they're able to touch your finger, like you just move your finger around, right? So here, do it to me. So touch your finger, touch my finger and then touch your nose. Again, cool. So you move them around so you can see if they're able to keep on doing that, right? Sometimes if they have some sort of damage, they might start kind of swiggling their finger around, right? So that you know that they're going to have some damages to the upper motor neuron regions if they're not able to move their hand. So those are all different types of things you can test for on a physical exam. Any questions on that? All right, cool. So this is the most common artery that's involved in strokes, the middle cerebral artery. So this is the most common one you'll see. And unfortunately, when you get this area getting infected, it's going to affect lots of different parts of your body, right? Because the middle cerebral artery is going to provide vasculature to the temporal portions of the temporal lobe, the parietal lobe, the frontal lobe, and then think about the central gyrus. You have the pre and post central gyri, right? So you guys probably are familiar with the homunculus, the little gnome-like creature that lives in your brain, right? So the homunculus is just a depiction of the disproportionate regions of the brain that are represented. So your hands are going to be disproportionately represented by your brain. Same thing with your face, right? So your facial muscles as well as your facial sensations are going to be disproportionately represented by your brain. So that being said, your arms get a little bit less representation, your body gets a lot less representation, and even your feet don't really have a terrible amount of representation either. Your hands are really important, right? So sensation as well as dexterity, right? Those are really important. So in terms of motor innervation to your hands, you have lots of real estate in your brain dedicated to your hands' ability to move, right? Same thing with your face. Lots of real estate in your brain dedicated to your face. Micro expressions. Think about communication. It's like over 60% of communication is nonverbal. That's like facial expressions, right? Even if a person has like a slight grimace that you don't even necessarily consciously notice, you subconsciously notice those signals, right? You can see that in someone's face. You ever see someone smiling at you, but you can tell that they want to probably bash your brains in, even though they're smiling, right? It's not a real smile, but you can still tell, right? You can tell just by looking at them. So that's why it's really important to be able to perceive people's facial expressions, because a lot of your communication is through expressions. Same thing with movement, right? So movement, expressions, and sensory input. Sensory input's also really important in the face too. So if you If you damage the middle cerebral artery, you're going to have damage to these regions that are really important for facial expression. That's why when a person has a stroke, they droop, right? Their face gets droopy. And then you'll also see paralysis and paresthesia on the affected side, right? And it's going to be the contralateral side, right? Because if it's the right side of the brain that's affected, it's going to be your left side that's going to be paralyzed, right? If it's the left side of the brain, as long as it's above the decussation of the pyramids, it's going to be the opposite side. So it's going to be the contralateral side. If it's the same side, it's called ipsilateral. And usually when you have an ipsilateral type of damage, it's going to be below the level of the pyramids, below the level of decussation. Decussation just means crossing over of those tracts. And so if you had spinal damage below the level of the pyramids, and you had paralysis, that would be considered an ipsilateral damage because it's already crossed over from the cerebral cortex to the opposite side. So if you have ipsilateral damage, usually it's going to be lower motor neuron type of damage. So yeah, this is all really important. So this is where the cerebral artery is going to be, or sorry, the middle cerebral artery is going to be feeding into. It's going to be these areas. So pre-central gyrus, that's going to be motor. Right? Think about the spinal cord too. You have your anterior and posterior ganglia, right? So your, dorsal and ventral. So ventral root ganglia in the front, those are motor, right? Dorsal root ganglia is all sensory. Very similar with what you got in the pre versus post central gyrus. Pre-central gyrus, which is going to be more anterior, is motor. Post-central gyrus, which is part of the parietal lobe, is going to be sensory. So if you have damages to those regions, you're going to get motor and sensory dysfunction. One way that you can test for sensory dysfunction is going to be the 2-point pinprick test. So you can have the person close their eyes, and dang, I should bring my neurological hammer. I have this really cool neuro hammer. It's like a reflex hammer, but it has built in like a little needle. It also has a little brush, so you can do like fine sensation stuff. I used to use it a lot when I was doing my neurology rotations, but it has a little needle. And so with the little needle, you can do 2 needle pinprick sensation. So you have the person close their eyes, then you take 2 needles, and then you ask them how many needles are poking you, right? If they don't have any sensory damage, they can usually discern from the sensory input that there's 2 needles poking them. If they have a little bit of sensory damage, then they're gonna perceive that as like 1 needle, right? You can do that on yourself too, because think about the homunculus here. On your hands, you have much more sensory input. So if you did 2 needle pinprick test, you'd be able to. You can do this to your friends maybe over the weekend. Maybe over a couple drinks or something, you can say, "Hey, this is something I learned in neuro." So you do like a 2-pin sensation. So you can have them close their eyes, see how many pins are poking their hand. Then you can do the same thing to their back. And in the back, you have way less sensory input, right? Because look at the homunculus. There's not much going on in terms of like the sensory input from the back. It's going to be really hard to determine how many needles are poking them in the back. They're going to perceive it as just 1 single needle. But if you had damage to the regions that innervate the hands or the face, you're going to also have difficulty perceiving that touch, right? If it's a really serious stroke, you might have no sensation whatsoever. But if it's mildly damaging, then you can still maybe feel a little bit of sensation. You can also do this with diabetics too. Patients with diabetes or long-standing hypertension, you can do that to their feet too. You can see if they touch, if they feel like a little like brush, like a little tiny, almost like a feather tickle, right? If they can feel it, that means that they still have sensation in their feet. But if they don't feel it, then that means they might have peripheral neuropathy due to diabetes or long-standing hypertension. So those are all different types of tests that you can potentially do to determine if those regions are affected and how badly they're affected. Speech centers. So these will vary depending on if you're right or left dominant, but most people are going to be right-handed, so these regions are mostly going to be seen in the left side of the brain. So that means left side dominance, right-handed, right? Left side dominance would be left-handed. Right side dominance would be left-handed. But for the most part, most people are going to have Broca's area and Wernicke's area as part of the left side of their brain. So what do these areas do? Broca's area and Wernicke's area are both part of speech recognition as well as production of speech. And so Broca's area, mostly speech production, And if you have damage to Broca's area, you're going to have a difficult time producing words. So you're going to have limited vocabulary. The other one is going to be understanding and recognition of speech, and that's going to be Wernicke's area. And one way that I can help you remember the two is that Wernicke's aphasia, if you have damage to that area, you have word salad. So you're speaking a bunch of gobbledygook and it doesn't make any sense, right? Kind of like what I'm doing today, right? So if you have damage to Wernicke's area, you have Wernicke's aphasia, and you're just word salad. You're talking and talking and talking, but it makes absolutely no sense. Versus Broca's area, if you have Broca's aphasia, you're going to have very limited speech. I'm going to show you a really cool video in a second that demonstrates that really nicely. I saw that for the first time in med school. This is actually the reason why I was so interested in neuro, is because of these different aphasias. I thought it was so fascinating that you can have those areas get wiped out and it can totally impair your ability to speak or even comprehend words. So let's see Wernicke's area first, Wernicke's aphasia. This is so fantastic. I love this video. I mean, it's sad, but it's so fascinating.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment, talking to people over them over there. They're guiding to them at the moment. They'll stay in the moment. He had water first. Yeah. Love. Yeah.
We're on a cruise.
We will see one right here and they'll say yeah.
And what were we just doing with the iPad?
Right at the moment they don't shut down.
The iPad that we were doing. Here.
I might change for me and change hands for me. Look happy. Talk with Donna sometimes. We're all with them. Other people are working with them. Very happy with them. This girl was really good and happy. And I play golf. Hit up trees. We play out with hands. We save a lot of hands on hold for people. I talk with a lot of hands. Sometimes. Talk with any more to say.
All right. Thank you very much.
Thank you very much. I appreciate it. Hope the world lasts you. Have a good day.
I hope the world lasts for you. That's funny. So poor guy, right? He doesn't understand anything that is being spoken to him, and he's not saying anything that makes any sense. So this is both auditory as well as written. So if you were to write things down, it's going to be just as confusing and mishmashed as it is when he speaks. Right? So that's word salad. What's up? That's a great point. When you have a stroke, you're going to have like defects in your perception as well. Like I talked about my dad having a stroke, right? I told you guys about that, right? He had an occipital lobe stroke, crazy hallucinations and stuff. So depending on what part of the brain is going to be affected, you're also going to have just like distortions of reality. You're going to have distortions of perception. And so this guy, you know, he probably thinks that he understands what he's hearing. He probably thinks that it's making sense when he speaks, but it doesn't, right? Usually with a patient with like Alzheimer's dementia, you know, kind of like our president, they get really frustrated when they can't find their words properly. And so they do get frustrated because they're like, I can't make the word. I can't figure out what word to say. And so you get a little bit of that when you have like Alzheimer's dementia, because they don't have distortions of perception per se, right? But they have like the defective ability to like, you know, engage with the world around them properly like they used to when they were younger. They could only communicate in profanity. Was it Tourette's? Are you sure it wasn't Tourette's? Oh, it did? I have no idea what the heck that is, but that's hilarious. So the guy had a stroke. Was it a stroke? Or was it brain injury? And he could only speak in profanity? Oh, man. I want to like use that as an excuse. I'm sorry, I have brain damage. That's funny. I've never heard of that before. I mean, outside of like Tourette's, and there's different types of Tourette's. Well, we can talk about Tourette's later, but Yeah. Anyways, yeah, Wernicke's aphasia is so interesting because of that. Yeah. I am going to show you a video right now then, because this one is like, this is the coolest thing that I've seen when I was in med school. I saw this when we were learning neuro, and this is the Tono man. This is Broca's aphasia.
We shall see how effective this patient is at manipulating his information and his utterance. The segments you will see are, first, the conversation about his upcoming move to a new house, followed next by a sample of his spontaneous automatic speech. Let's count it out. 1, 2, 3, 4. One, two, three, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 1. Isn't that wild? So in other words, the different regions in your brain are responsible for different types of processing. So there's a different region in your brain that's going to be associated with numerical processing. And when you're speaking those words that represent numbers, that's going to be a different part of the brain outside of Broca's area. But as soon as you start getting into more complex numbers, 12 and above, then it reverts back to the language center. And so now it's going to start seeing, you're going to see the effects of the Broca's aphasia. So I never saw that video with the musician or the singer, but I'm going to try to look that up. Actually, if you could do me a favor, could you find that and send it to me? And then I'll actually include that in my future presentations too, because that's really fascinating. So in other words, the person couldn't speak, but when they were singing, they could sing it. Would they be... Muscle memory. That's fascinating. That is so fascinating. Yeah, I definitely want to see that video. I'll include that in future lectures. Let's see another one on Broca's area. And by the way, when you saw that video, he obviously understood what he was being asked during the conversation, right? He was responding to the questions. He was like, counting the numbers. So he had word comprehension. So he was able to understand what was being spoken. What's up? Yeah. Oh, okay. That's a good question. I actually don't know off the top of my head. Let me look into that because it's speech production. So it's like the motor skills of speech. He was kind of like writing it out, so I don't think he's going to affect his writing. I think he might be able to write things out. So let me verify that real quick. Let's just watch this video, and while we're doing that, I'll do a little Google search.
This installment, I'll discuss Broca's area. Although the anatomical definitions of Broca's area are not completely consistent, it is generally considered to make up some part of a region called the temporal gyrus,
found in the frontal lobe. In the vast majority of individuals, Broca's area resides in the left cerebral hemisphere. Broca's area was named for the physician Paul Broca, who first identified the region as playing an important role in speech production. Broca based this hypothesis on case studies that damage to the area and also displayed a deficit of speech. The particular condition Broca observed came to be known as Broca's aphasia and involves a deficit in the ability to produce language. Patients with Broca's aphasia, reading and writing are also often impaired. The language comprehension is
There we go.
relatively preserved. The precise role of Broca's area in language production, however, is still being debated. In other words, damage to Broca's area can disrupt language production. Nobody is quite sure exactly what language-related function is lost to cause that disruption. Some have hypothesized Broca's area is involved with producing movement, like the tongue and mouth, that allows speech to be produced. Others have argued it is involved with syntax, grammar, verbal working memory, or all of the above. Broca's area is also thought to have a variety of other linguistic and non-linguistic functions. It has been recognized as playing an important role in language comprehension, movement, and even understanding the movement or actions of others. Thus, although Broca's area does appear to play a role in language, the overall function seems to be more complex.
So the answer to your question is yes and no. All right, so written language, when you have Broca's, from what I read here in an article on Science Direct, it's saying that Broca's aphasia, you might see analogous impairment on written language as well, compared to the spoken language, but reading ability is only going to be mildly impaired, according to this. I imagine there's going to be a gradation of severity as well. So it depends on how severe the lesion is. Probably. The Tono man would probably write Tono. I'd be curious to find out. They should have done that in that video, shouldn't they? Yeah. I don't know if there's any videos out there that go beyond what was on that YouTube video, but that's all that I've seen from the Tono man. Hope he's okay wherever he is. Considering how long ago that video was made, I don't know if he's still with us. But anyways. All right, so aphasia. Broca's aphasia, to summarize, is going to be non-fluent aphasia. So, in other words, you're non-fluent, you're going to be very restricted in the amount of words you can produce, right? So, tono, as an example from that one gentleman. Versus Wernicke's aphasia, it's fluent, but it makes absolutely no sense what the person's saying, right? So, it's all just word salad. They're spouting out a bunch of words, and it doesn't really make much sense whatsoever. And then this question here, how would you communicate with the person with Broca's aphasia? I mean, you could just talk to them, or you could write to them as well. They could understand. They should be able to understand most of written language. But anyways, here's another summary of all that. If you understand what the person is saying, Broca's aphasia. If it doesn't make any sense whatsoever, it's going to be Wernicke's aphasia. All right. All right, any questions on aphasia? What's up? I don't imagine that they would be able to do that. I don't think they could. I mean, you could look it up and find out and see, but I imagine that there would be severe limitations. Learning sign language is like learning a language all over again. So I think a lot of these people are going to be older, so it's going to be harder for them to learn new skills, and it's going to be somebody who had a stroke. So it's going to be really hard for them to, I think, pick up any sort of new skills whatsoever, just because of that. That is such a great question. I have no idea whatsoever. I have no idea which areas of the brain are. I think sign language is going to be a combination of everything. Motor skills, like word association, things like that. So if I were to make a BS guess or an educated guess, I would say that their abilities for sign language would also be impaired. But I don't know for sure. But that's a really good question. If they had previously known sign language and then had a stroke that affected Broca's area, if that would affect their sign language abilities, I think so. I probably think so. Look it up. Look it up and let me know. You looked it up? You did? They would have difficulty? All right, so there's the verdict. They would have difficulty in sign language too. So those are really cool, huh? Those are really interesting neurological deficits. I think they're some of the most interesting out there. And not as depressing. The other ones are really depressing, right? Those ones are kind of more, it's sad, right? It's very sad, but it's not as depressing if they're like totally paralyzed or something. All right, facial palsies. Now this is also a really important distinction, because if you have facial palsy, it could be one of two things. It could be an upper motor neuron lesion, like a stroke, or it could be Bell's palsy, which is not a stroke. And so it's good to know what's going to be affected, which parts of your face. So think of your face as being 4 quadrants. So you have your right upper, left upper face, and then you have your right lower and left lower face. Now, if you have something like a stroke, it's only going to affect the lower part of your face. It's not going to affect the upper part of your face. When you think, oh, the person's entire side of the face is like paralyzed, that might seem more startling, but that's actually a better thing than if it was just one part of their face. If it was just the lower quadrant, then if it was lower quadrant, it's probably a stroke. Versus the whole entire half side of one face being affected, it's going to be something more like Bell's palsy, which is lower motor, which is way better because it's not a stroke, right? And so when you think about the way that the facial muscles are innervated, upper motor neuron lesions, you're going to see bilateral innervation, and you're going to see it decussate. So it crosses over, and then the lower half is the only part that's going to be affected when it's a stroke, if it's upper motor neuron lesion. If it is a lower motor neuron lesion, that's going to be peripheral, and that's going to be Bell's palsy. With Bell's palsy, the entire half of the face is going to be affected. Stroke, upper motor neuron lesion, only one quadrant is going to be affected. And so here's a picture of a dude that had Bell's palsy. Over time, it resolved. Bell's palsy, for the most part, resolves spontaneously over time. There's rare instances where it's permanent and it lingers longer. There was a gal that I went to med school with. She had Bell's palsy, and she just had it. And she had it for a long time. And, she would smile, and she would only smile from one side of her face, basically. But for the most part, it's going to resolve on its own. So who gets Bell's palsy? People who have viral type infections. So it could be either post-viral or latent type of viral infection. So upper respiratory tract infections. Herpes simplex virus is going to be common in this, so HSV1. Varicella zoster virus as well. And Epstein-Barr virus is going to be another common type of virus that can cause Bell's palsy. And it's going to be affecting cranial nerve 7. It's going to be folks that are before less than 15 and then over 65, so very young and older patients, and also individuals that are pregnant women. And sudden onset, it just happens suddenly, and all of a sudden you get paralysis, unilateral. You get droopy mouth, and then your eyes are also going to be affected. When you have the inability to close your eyes, what's a big concern with that? Huh? Sleeping? What? Yeah, and what does it cause? Corneal ulceration. And so if you don't have like lubrication or tears in your eye, big concern is corneal ulceration. And think about your cornea. Try to poke your cornea, it hurts, right? So if you ulcerate the cornea, it's really painful. So these patients, they want to use like eye drops, also an eye patch too. They might want to put an eye patch on so it keeps your eyes closed. Those are things you might want to consider for treatment for patients with Bell's palsy. Testing. It's going to be, you want to do a CT scan. You want to do a CT scan because even though you think it's Bell's palsy, you still want to try to rule out the possibility of there being a stroke underlying, right? So definitely want to do that. Of course, physical exam, you're going to see that the entire face is affected. Treat it. It's inflammatory, so you want to give them corticosteroids. and then eye patch to prevent the corneal ulceration. And most people are going to recover. However, some people do not fully recover. Right? There's going to be a small percentage of people that just they'll have this for the rest of their life. And it's pretty rare, but it does happen. Cool. What's up? For a stroke, you can see the area that gets affected from a stroke. You'll see discoloration on the CT scan. I forget what it's referred to. I think it's opacity, I think, is increased in an area that's affected by stroke. But you can see that on a CT scan. So look up pictures of stroke on CT scan. You can visualize that pretty easily. Oh, he did? Justin Bieber had Bell's palsy? When was that? Oh, really? Oh, that's... Oh, that's funny. I'm glad he's doing better now. That's funny. All right, let's do some quizzes questions. I got 14 questions for you, so we'll soldier through these and then continue on afterwards with seizures. All right, let's begin. And so one of the options there was conducting aphasia. Conducting aphasia is a little bit more mild, and there's a disconnect between processing as well as producing language, so you have a difficult time repeating a word or a phrase. And so if you wanted to treat that, you could do that with like speech therapy. The speech therapists that usually work in hospitals that work with stroke patients, especially, so that they can try to get back to speaking again. So yeah, this person, meatballs, because Jimmy crashed the party. Yeah, I mean, he's fluent in speech, right? But the speech makes no sense whatsoever. So that would be a Wernicke's aphasia. That's considered word salad. Cool. Yeah, that was the more correct answer. B, kind of, sort of. Stroke symptoms usually accompanied by difficulty walking. Bell's palsy does not affect mobility. It does affect mobility of the face. That's not exactly the correct answer. good. That's a classic example of Broca's aphasia. And if you were to say tono, 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 then that would be the tono man, right? So, moving on. Cool. So this is a TIA, right? One of the things to keep in mind with this patient, they have all the risk factors for stroke, but those are all the risk factors for TIA as well. So hyperlipidemia, especially type 2 diabetes. Symptoms resolved within an hour, right? So this is not a hemorrhagic stroke. If this patient had a hemorrhagic stroke, it would not resolve within an hour. That patient would be in a lot of trouble and would have a long recovery if they did survive. Other things to keep in mind about this patient. So they had CT scan. It showed no evidence of hemorrhage. So that immediately rules out a hemorrhagic stroke. And yeah, there's a small ischemic lesion on MRI. If you have a tiny little lesion that's ischemia, that shows ischemia, then that's going to be more in line with a transient ischemic attack. Now, that being said, what's the prognosis for this patient moving forward? They should probably change things in their life. Like they should probably start getting on meds, to maybe like blood thinners, things like that, right? Because this patient is a ticking time bomb. A patient that gets TIAs, they are well on their way to developing a full-blown stroke at some point. So this is kind of like a red flag, right? It's a canary in the coal mine. You want to make sure that this patient starts getting treated because they have a high risk for stroke. Don't worry, I'm not going to judge you. Oh. Oh no. Which one did you choose? Sinusitis? Just kidding. Oh my, you chose migraine for this. Yeah, I'm pretty sure their brain is bleeding, especially considering their imaging studies, non-contrast head CT shows intracerebral hemorrhage, right? So this is obviously a hemorrhagic stroke, not a migraine, Trent. You brought it upon yourself. So low cholesterol is a good thing. High HDLs, also a good thing. If you had high LDLs, that's a bad thing. Right? So that would be a risk factor. Exercise, obviously a good thing. High High blood pressure, that's a bad thing, right? That causes atherosclerosis. And then an arteriovenous malformation, that's also really bad. That person is going to be a high risk for hemorrhagic stroke. You got all these like poorly made blood vessels, and those could easily rupture. Transient hypertension, right? Because when you're out jogging or whatever, your blood pressure is going to go up, your heart rate's going to go up, but it's temporary, right? And it's a good thing. Yeah, you want people to be exercising, especially if they have risk factors. You know, you want to tell them the diet and exercise. Those are the two major things, lifestyle modifications. So yeah, it does cause temporary increase in blood pressure, but it's in a good way. I like your logic though. That was good. You don't want to discourage people from exercising. All right, super easy question. That was a total softball question. What? Yeah, you want that on the exam? So last week, I'm not going to name any names, but I had a colleague of mine. Him and his wife, they're both healthcare practitioners. Well, sort of healthcare. His wife is more of a healthcare practitioner. But anyways, they had already planned in advance what would happen if they were to wake up in the morning with a stroke. And if it was an ischemic stroke, they said that if they got it when they get admitted to the hospital, they're going to lie to their doctor and say that it happened within 3 hours. Because if you were sleeping and you wake up and you're like paralyzed, right, because of a stroke, and you get sent to the hospital, if they can't determine how long you've been stroked out for, then they're going to be really reluctant to give you TPA, because the cutoff for TPA is within 3 hours. Beyond 3 hours, it's at the discretion of the neurologist or the neurosurgeon that's involved, because the biggest concern is that a ischemic stroke can, within a period of time, convert into a hemorrhagic stroke. Because when you kill those tissues, right, you might bust the vessels. The vessels could eventually hemorrhage too. And if you give the person TPA, then they're going to bleed out really fast. But think about how bad having a stroke is. And if you just get given like aspirin to treat it, you're not going to really get a great recovery. So that's the reason why my colleague said that he would lie about it, because he would prefer to take the risk of getting a bleeding hemorrhagic stroke after getting TPA than not treat the ischemic stroke to begin with. So I thought that was a really interesting argument, and I totally get that. Because when you tell the doctors, when you get to the hospital, how long has this been going on for? Like, I don't know, over 3 hours, they're going to not want to give you TPA. So that's part of like the protocol with TPA. So the story with this patient, the big thing is the CT scan showed no hemorrhaging, and it happened within 90 minutes. And so this patient would be an ideal candidate for TPA. So this would be within the guidelines for stroke management. Good. Most of you guys got that right. That's awesome. This one is going to be a tricky question. We didn't talk about it yet. It's a real condition. I don't even know how to pronounce it really. Arachibutyrophobia. Oh my god, no, forget about it. Do you guys know what the term is for fear of clowns? It does start with a C. It's coulrophobia. Coulrophobia. No, it's not going to be on the exam. It can be on the exam. I could put it as an extra credit question. What's fear of spiders? Arachnophobia, yeah. What's the fear of going out into public? Agoraphobia. Good, that's great, yeah. It's actually not just going into public. Agoraphobics, they're afraid of dying in public. They're afraid of being seen dying by other people. That's one of the major reasons why they have that fear. So we're going to talk about psychiatry later on. But yeah. Good, that's a softball question. Bacterial infections can increase your risk of septic shock. All right, gosh. The next few questions are all softball questions. So yeah, if you're puking your guts out, hypovolemic shock. uh, yeah, you might see one or two of these on the exam. There you go, 100%. Nice. Cardiogenic shock, yes. All right, let's see if you guys get this last one. So you're telling me that 20 seconds is too long for these questions? Yeah, so peanut allergies would be anaphylactic shock. All right, good job, guys. That was awesome. Let's move on now and start talking a little bit about seizures. Congratulations, Jessica. All right, let's move on. Cool. I really like this painting a lot. This painting was done in the 15th century. And, you know, the painting is about demonic possession. But the reason why I put it on here is because back in the day, people thought that when someone had a seizure, they were demonically possessed. And I don't think a lot of those cases ended well for the person having the seizure. Yeah, there's a lot of interesting things when it comes to, like, you know, the way, you know, theology kind of played into, like, medicine, the way things were practiced. Yeah, so kind of interesting. I really like this patient, especially for this guy. What's going on over here? It's like floating out of a wall or something. So I think he's the one that's demonically possessed over here. But anyway, so seizures, yeah, they can look like demonic possession, right? So historically, they used to be considered demonic possession. What is a seizure? Back when I was doing lots of neurology rotations, one of my preceptors described a seizure as one neuron starts to party, and starts to party a little bit too hard, and the party is contagious. Like all the other neurons want to party along with the crazy neuron, And so all of a sudden the party just spreads to all the other neurons. So it's like a contagious discharge of electric signals, right? So you have uncontrolled neuronal firing in some part of the brain, and then eventually that becomes contagious and it spreads either to one area of the brain, so that'd be a partial seizure, or it goes to the whole entire area of the brain. So those would be more complex type seizures. So it's abnormal electric discharge, and because of the abnormal discharge, it's going to affect your motor regions, right? So you're going to start getting involuntary movements. It could affect your visual cortex, so you can start seeing things. It could affect regions that allow perception of smells, like olfactory sensations. So you might actually perceive weird smells. You might perceive weird tastes. So these are all different types of things you might see with seizures. If it's very severe, like we're going to talk about later with like grand mal seizures, sometimes those people, well, sometimes they lose consciousness. Like they have no idea what the hell happened. And they wake up and then they're going to be drowsy because they're in a post-ictal state. And so we're going to talk about the different signs and symptoms that are associated with the different subcategories of seizures. And what are some of the things that can cause seizures? Yeah, so drugs, trauma, right? If a person gets a brain injury, they can be more predisposed to getting seizures because sometimes you might get a little scar tissue, and that would be like the foci of the seizure. You can actually try to determine that by using CT scans, MRI. You can also do like EEGs, which are electroencephalograms, so you can maybe see where the origin of the seizure is. Cancers, so tumors can cause seizures. And so there's a lot of things that could underlie a seizure or why a person might be getting seizures. Fevers can cause seizures too. And you had a question? Yeah, the aura is going to be kind of the beginning period where you start seeing stuff, right? And maybe you start smelling things, you might be tasting things. That's like where the seizure starts to build and develop, right? So yeah, so the aura is going to be preceding the seizure. So the question is, some people who have epilepsy have service animals. I think that's just an excuse to have a service animal. I have no idea. What is it? What does it do? Like he notices before they go into a seizure? Oh wow. I've never seen that before. That's interesting. So it's not just an excuse to have a service animal. That's cool. So the dog actually rolls the person over. That's really cool. Yeah, because that's one of the ways that you want to treat or if you see somebody seizing, you want to roll them over to the side. Otherwise, they might swallow their tongue, right? Or they might aspirate, which can cause pneumonia. So yeah, the service animal can actually do that. That's cool. Otherwise, I don't know. No kidding. That's amazing. That's really cool. All right, so yeah, yeah, that's amazing. That's super cool. I was not aware of that, but very cool. Service animals. I like dogs. Dogs are awesome. Not a big fan of cats though. Sorry. Anyways, so convulsions. You get convulsions. So those are involuntary movements, jerky type movements. And then what's epilepsy? Epilepsy is when you have two or more unprovoked seizures. So if you have a seizure, that doesn't mean you have epilepsy. If you have epilepsy, that means you have seizures, right? And what happens when you get diagnosed with epilepsy? The thing that sucks, besides the actual like medical component to it, the other thing that really sucks is you can't drive. So you get your what? Yeah, yeah. So you can't watch. Yeah, you can't watch anything that has like flashy lights. But the most important thing is you get your driver's license taken away, right? Because you don't want somebody on the road driving 80 miles an hour down the I-10 and then all of a sudden just going into a grand mal seizure, losing consciousness. That person is a risk to themselves and others at that point. I had a student that was diagnosed with epilepsy. She was like on the verge of getting her license back. And then, bam, she had a seizure. And so she had to get her license. They had to extend it, I think it's like a year, I think it's a year. So she had to get it extended again. Oh, I felt so bad for her. But it's just it is what it is. And then when you have those reoccurring seizures with epilepsy, sometimes it's because the drugs you're taking aren't at a dose that's high enough to control the seizure. Or sometimes you have to switch drugs, right? Maybe you're on carbamazepine and you got to get switched on to phenytoin or something like that. Or Lamictal. Those are some more more potent type drugs that are really well tolerated. So I don't know. Sometimes you have to just switch over the drug, or maybe sometimes you have to increase the dosage of the drug. So yeah, causes, alcohol withdrawals. We're going to talk very briefly on delirium tremens and alcohol withdrawals. Drug use can cause seizures, fever, so those are febrile seizures, trauma, tumors, infections, and strokes can cause seizures as well. So this is DTs, or delirium tremens. This is going to be due to alcohol withdrawals. And so when you have alcohol withdrawals, the big thing that happens with alcohol withdrawals is that you can go into autonomic instability. So if you're drinking booze all the time and you get that neurological effect from the alcohol, what does the alcohol cause in terms of neurological firing? Yeah, it's a neurodepressant. It doesn't mean that it makes you sad and cry and get all emo in the corner, although it could do that, right? Depending on how you're feeling. But in reality, it just causes neurodepression, right? It slows the brain down a bit. It's very similar to benzodiazepines, right? So if someone has anxiety, they might take Valium, they might take Xanax. Those drugs operate on the GABA receptors in the brain. And when you induce GABA receptors, it causes neurodepression. Alcohol, it hits all the neuroreceptors in your brain. It hits opioid receptors, it hits dopaminergic receptors, but it also hits GABA receptors in the brain. And when alcohol hits GABA receptors, it causes neurodepression. Now, if you're a chronic alcoholic, you're going to be stimulating your GABA receptors all the time. What happens when you stop stimulating the GABA receptors? GABA receptors are not going to get stimulated, and so now you have excitability. So you have hyperarousal. And so that's kind of what happens with alcoholic patients, right? So the big concerns are when their blood pressure goes up. So when they have elevated blood pressure, they have elevated heart rate, their temperature also goes up. Those are all scary signs that the person is really high risk of going into delirium tremens. And so those patients go on Ativan protocol. So when they get admitted to a hospital, they'll be given Ativan, which is a benzodiazepine. And Ativan is going to help to put them back into a state of neurodepression, which is a good thing. You want that to be done for those patients. But if you get delirium tremens, that's where you start getting seizures. The DTs and all this is really dangerous. So these patients, if left untreated, can die. Right? When you go into autonomic instability, you can have cardiac arrhythmias, you can go into a coma. So this is scary. You want to make sure that you avoid allowing a patient going to DTs. So you want to prescribe them some sort of benzodiazepine. God, I was talking to one of my colleagues way back in the day when I was doing my clinicals. He said sometimes they even prescribe one beer. And so at the hospital I was at, they actually kept beers over there just in case that an alcoholic patient come in, because you don't want the patient to go into DTs. This is life-threatening. The patient could die. So what does it look like when you have a seizure on an EEG? So this is an EEG cap. You put this cap on. Generally, they're going to slather your head with conducting gel, and so you get some good conduction. EEGs aren't the perfect. They're not perfect, right? Because you're measuring electric signals coming from your brain. But guess what? There's a lot of things between your skin and your brain, right? You got bone, you got blood, cerebral spinal fluid, you got other tissues over there, you got hair, right? And so it doesn't give you a perfect read of electrical activity, and it's going to be more of the superficial activity on the cerebral cortex. But what EEGs can do, they can tell you when the seizure is happening. They can tell you how long the seizure is happening. And they can also kind of help you try to locate where it starts in the brain. And so if you know where it's starting in the brain, it gives you like other cues or clues to where to look for if you're like doing a CT or an MRI. So you can see maybe there might be like scar tissue from trauma. Like people who get, TBIs, traumatic brain injury, they could get scar tissue, which can cause seizures. If they have cancer, a tumor, that might be like the foci of the electrical signals taking place. This is another, you're not responsible for the stuff on here, but this is kind of like the different types of things that could cause seizures depending on the person's age. Kids, you're going to see lots of febrile seizures in kids, not as much adults. When a kid has like a high fever from some sort of infection and they start seizing, that's going to be a febrile seizure. Encephalitis can cause seizures. Tumors can cause seizures. There could be drug use in adolescence, right? Stimulants, cocaine, amphetamines, those type of drugs, tumors, all these things can be the underlying cause of seizures. So let's briefly go into febrile seizures. So you have a young individual, a child, and they have a really nasty infection of some sort, and their temperature goes up, they become febrile. Above 102.2 is where you start seeing a higher risk for febrile seizures. And it's going to be younger individuals. So infants all the way to children, right? So young adolescents. And these are going to be generalized. So generalized meaning it's not partial. Partial means only one part of the brain. Generalized is going to be the entire brain. You get electrical signals all firing simultaneously around the entire brain. And by the way, with kids, they have a lower seizure threshold. This is why that's why you don't see this in adults as much, right? You're going to see this more in kids. They have a lower seizure threshold. Now, generalized seizures are a little bit different. Right? Generalized seizures are going to affect the entire brain. And so these are the stages of a generalized seizure, and I want you to be familiar with these. So when you first start getting symptoms that the seizure might happen, this is going to be the prodromal stage, and that can happen for a long time before the seizure actually takes place. You might start getting a little bit mood disorder. You might start feeling a little depressed. You might be getting headaches. You might get changes of your mood. Maybe you're becoming insomniac for a couple days leading up to the seizure. Then the aura, which is one of you all, I think it was Macy that mentioned this, the aura, right? Yeah, so the aura is going to be right before your seizure takes place. And that's when you start getting hallucinations. You might get weird smells. You might hear weird sounds. You might get weird tastes in your mouth. Those are all hallucinations that are within the aura space of this like progression. And then when you actually have the seizure, that's called the ictal stage. Then that lasts, it can vary how long it lasts. It depends on the severity of the seizure. But it can last minutes, maybe longer than that. And then eventually, when the seizure is done, then you go into the post-ictal stage. And the post-ictal stage is where the patient is now going to be tired, they're going to be lethargic, they're going to be confused. So anybody that has a grand mal seizure, when they come back to, they're going to be really confused. They're going to be exhausted. Why they're exhausted? Their brain just started firing like crazy, right? So it's like using up lots of ATP and energy, right? So they become lethargic after everything is done, right? So it's like the hangover after the party, right? So the brain parties too hard, and at the end, now it's going to be really exhausted. What's up? You had a what? They had like paralysis and stuff, and like, oh yeah, yeah, that makes sense. I mean, yeah, they get very confused and very tired. So that is what you see with the progression of a generalized seizure. So let's watch a video on that.
When I have a seizure, first of all, I get this weird taste in my mouth. I can't describe it properly, but when it happens, I know I don't know what is going on around me. And then I wake up on the floor. I'm really confused, and all my arms and legs hurt. And sometimes I even wet myself, which is so embarrassing. Mum says what actually happens is I fall down and my arms and legs shake a lot, and she can't wake me up. She just has to wait until it's over and check that I'm safe. It only usually lasts a couple of minutes, but afterwards I am so tired I have to sleep for the whole day. I don't like having them at all, and sometimes I get scared, but I know that my family and my teachers and some of my friends know what to do to make sure I'm okay. And I've stopped having so many since I started taking my new medicine.
If someone has epilepsy, this means they have seizures. Your brain is like a computer that controls your mind and your body. It does this by sending electrical messages. During a seizure, these electrical messages get mixed up. There are lots of different types of seizure. Every person with epilepsy is affected in a different way. It really depends on what type of seizure you have, but they are all due to your brain signals getting mixed up in a short time. Find out more about epilepsy at epilepsy.org.uk.
Right. Cool. So this is a really good chart. This is going to help you like summarize all the different types of signs and symptoms that are associated with the different types of seizures that you're going to be responsible for in this class. So this is going to be subdivided into partial versus generalized. Partial only means that you're affecting one side of the brain. Generalized, globally, right? It's going to be affecting both hemispheres of the cerebral cortex. Partial seizures are going to be divided into both simple partial and complex partial. With both of these, you're going to see, well, not full loss of consciousness. Simple partial, you don't have loss of consciousness. You're like aware of what's going on. This one, complex partial, it's a little bit more severe, but you're not going to lose consciousness, but you're going to have altered consciousness when you have a complex partial. With a simple partial, you don't have any of that post-ictal confusion. You're aware that you're having a seizure, and then you're not going to be confused when it's done, right? Whereas with the complex partial, you do get post-ictal confusion. So it's a little bit more severe. Only parts of the body are going to be affected where the region of the brain is affected, right? So if it's like regions that are associated with like the motor cortex, you're going to see motor involvement. If it's going to be involving like the face, motor cortex of the face, you might see like movement of the face, like lip smacking and things like that. And it's going to be pretty quick in terms of its duration, so less than 1 minute. Complex partial, you get altered consciousness. No, you don't have a memory of the event though. You lose memory. And you do get post-ictal confusion. You also get lip smacking with complex partial, and it's going to last a little bit longer. Then on the other side is where you have your generalized. That's all like all different regions of your brain are going to be affected. This one over here is kind of interesting. The petit mal or absence seizure, kind of interesting. It happens a lot to like younger individuals, and it looks like they're daydreaming. They're just kind of like staring off into space, and they just kind of like have a glazed look over their eye. And so basically the whole entire brain just kind of freezed and stopped working. And so you get staring spells. They're just like staring off into space. You'll often see like in a vignette, the child's teacher in school says that the kid like daydreams or zones off and doesn't pay attention. So that might be something that you would see on a vignette. So you get staring spells, you get altered consciousness. You don't get the post-ictal confusion. The moment the person comes back to, they act like nothing happened, which is like very strange. I'll show you a video of what that looks like in a second. And you don't get lots of consciousness in that. So the kid, if they're getting the petit mal seizure, they're going to stay there. They're going to be like present, right? But they're going to be kind of like daydreaming. What's up? Blinking eyelids is one thing that you could see with that. So I'll show you a little video of a kid that's getting a partial seizure, or a petit mal seizure. Kind of interesting. They're very quick. They last less than 20 seconds, and like I said, younger individuals. This is the bad one, the really bad one. The grand mal tonic-clonic is awful. You get everything, right? So you're going to get the auras, Right, so you get the prodrome, then you're going to get the auras, and then when it happens during the ictal phase, you completely lose consciousness, you fall down to the ground, you have no memory of what happened, you do get post-ictal confusion, and then there's 2 stages during the ictal period. You're going to get tonic and then clonic. So tonic, clonic, we're going to talk about that. So with tonic, they start tensing up, and then clonic is where they start getting convulsions, and they start having these like uncontrollable muscle contractions. So it's way more severe. So here's some treatment options for these. Carbamazepine is kind of like a very like standard classic anti-epileptic drug. There's other drugs that are better. So like, you know, Keppra, for example. Phenytoin does have some like pretty nasty side effects, but there's other drugs that can be a little bit more effective than carbamazepine. But then for absence seizures, specifically ethosuximide for younger kids that have absence seizures. So let's go first into the big one, the tonic-clonic grand mal seizure. So this is the one where it's much more severe throughout both hemispheres. So this is global, right? It's affecting both cerebral hemispheres. You get the prodrome period, so depression, mood disorder, things like that leading up to it. Then you get the aura, and the aura is where you start hallucinating stuff, right? You start smelling things, you start tasting things, hearing things, right? And then you have the ictal phase. First starts with stiffening, so you get tonic, and then after that you get the clonic, the movement of jerking, uncontrollable movements. So that's really scary when you get that. And then another thing you could see too, when you have these patients getting a general grand mal seizure, look in their mouth. If you look in their mouth, you'll see lots of biting. And I get really bad aphthous ulcers if I get a cut in my mouth, and it freaks me out when I see someone biting their tongue. The last time I saw a patient with grand mal seizures, he had the first seizure. It freaked his girlfriend out because he never had a seizure before. He like fell out of bed. He didn't know what happened, but he was biting his tongue like crazy. And I saw his tongue, it was just everywhere, just like massive bite marks in his tongue. So yeah, extremely painful tongue biting, and that's all because of the clonic phase. Post-ictal period, you get super confused, lots of consciousness, and then muscle weakness. Don't ever try to put anything into their mouths, right? So you want to make sure that you're not digging in their mouth, trying to like pull their tongue out or something like that. You just want to lay them over to their side. You want to prevent aspiration. This video is going to talk about putting suction in their mouth. They're going to suction because they're producing lots of like saliva and stuff. So the suctions are going to be made of rubber, so it's not going to damage teeth. But if you like put your finger in their mouth, they might bite you. If you put anything else in their mouth, that might damage their teeth. They could crack their teeth. They could get teeth fractures because of the tonic stage of the ictal phase. So let's watch a little video of this. It's pretty unsettling, but. So notice he stopped moving here.
He does. Okay. Yeah. Okay. Okay.
Poor guy. So you can see why back in the day they would think that was demon possession, right? It looks like what you see in the movies, right, for demon possession. So it's really sad. It's very dramatic. I've seen lots of patients that were having tonic-clotting seizures, and it's really difficult. Like they'll be biting themselves. So the first time I saw it was when I was working in Dominica. This lady they had to switch her meds up because she was having these breakthrough seizures despite taking her anti-epileptic drugs. And she was frothing blood. It was like bloody froth because she was biting her tongue. It was horrible. So really difficult to treat those patients. You really have to manage them with their meds. And the interesting thing about seizures like that, when you get those grand mal seizures, there's also other predisposing factors that can trigger a seizure. If you drink alcohol, if you do any drugs, sleep deprivation. So if you have like really bad sleep patterns, that could predispose you to getting seizures. If you have epilepsy, right? So you want to regulate your sleep, you want to regulate your diet, you want to regulate alcohol consumption. There was a gal that I met when I was doing my clinicals in New York. Julia, what was her name? She's an actress. And she was telling me about because it was a New Year's Eve party and she wasn't drinking. I was like, what, you don't drink? And she's like, no, I don't because I have seizures. And so she's actually like sober Sally. She's super clean. She doesn't do any drugs or alcohol or anything like that. And it's because if she drank, she would have an increased predisposition to getting seizures as a consequence. So good on her. It actually encouraged her to have a very healthy lifestyle, unlike a lot of people I imagine in Hollywood. So absent seizures. These ones are really interesting because it looks like they're daydreaming, right? So it's going to be younger kids. It is general, so it's going to involve the entire brain. There's going to be no prodromal effect, right? Unlike the grand mal seizures, there's going to be no loss of consciousness. There's no postictal period, so they just basically snap right back into it after the seizure's done. It lasts a very short period of time, just seconds. And then the patient is completely aware afterwards. Some teachers might think the kid is daydreaming. Maybe the parents think the kid's daydreaming. They might think that the kid has ADD, right? So these are all differential diagnoses, but those would be misdiagnoses, right? So let's watch a little video on this. This is actually really cool. And then he just literally snaps right back into it. Super interesting, huh? I don't know if that's a real video or not, but that's kind of what it would look like if it was real. I think that was real. Was it real? Maybe it wasn't real. But anyways, that's what it would look like if it was real. All right, let's change gears then. Now let's talk about the partial seizures, though. These are only on one region of the brain. Electrical disturbances only in one part of the brain. So you're not going to get the aura. You're not going to get the loss of consciousness. So this is a simple one, right? You're not going to get loss of consciousness. You're not going to get memory loss. You're not going to get the post-ictal confusion. It's short, so it's going to be below 1 minute. And it depends on which part is affected. Depending on which part's affected in the brain, you're going to see different signs and symptoms, right? So if it's in the arm, motor cortex that allows for innervation of the arm, or signals that it's sent to the arm, then you'll see like twitching of the arm. You might see twitching of the face, legs, etc. So in terms of sensory changes, you might get tingling, weakness. You might hear sounds. You might get those hallucinations, right? The smells, the taste, the visual perception. Here's a common one, the smell of burning toast. Burning toast, though, can also be associated with migraines, too. So migraines, when people get migraines, they can get auras as well. So they might get the auras. They might get visual scotomas. We'll talk about migraines later on. Like the first time I got a migraine, I had like blind spots. I was freaking out because I thought I was going blind. And then my neighbor, like, no, you're just having a migraine. And so like 20 minutes later is when I had the throbbing headache. And then I also had like temporary memory loss too. Like I was looking through my phone book. This is back when I used to write my friends' names in my phone book. And so I was like, who is this person? Like, these are all my friends, but I didn't even remember who they were because I had like changes in my memory too, but it was temporary. So you can see similar things in migraines as well, depending on the severity of the migraine. So you can see auras. We'll talk about that more later. This is the coolest thing in simple partial seizures, is the sensation of deja vu, right? Deja vu, it's like, oh, I've experienced this before, right? That's what deja vu means. It comes from French, which means you've seen it before. So deja means you've already seen it. Vu means to see. So deja vu means you've already seen it. And then hallucinations, of course. You might get fear and anxiety as a consequence. So other people might not even know that you're having the seizure. So it could go unnoticed. And then even the person that got it might even just call it, something funny just happened. They don't really know. So these can change. These can vary in gradation, right? Some can be more serious than others. This is where it gets a little bit more serious. It's still partial seizure, but this is the complex partial seizure. You might see auras. You might see memory loss. And the person's going to be awake, but they're not really going to be responding. You might get post-ictal confusion as well. The time is going to take a little bit longer. And this is often due to trauma of the brain or infections. Signs and symptoms, they're not going to be responsive. They might have these like movements, right? Purposeless behavior, lip smacking, chewing, stuff like that. Emotional outbursts. People might think that this person is just drunk. So differential diagnoses. You might think that they're drunk. You might think that they're like on drugs or something. You might just think that they're just being super aggressive for no reason. So those are all differential diagnoses. Let's watch a little video on that. So picking at the shirt there. So definitely not as dramatic as the grand mal seizures, right? But you just get these weird, repetitive type behaviors, you get twitching, things like that, staring off into space. So that's one of the reasons why if you were talking to that person, all of a sudden they go into a seizure like that, you might think that they're just like not paying attention to you. You might perceive them as being rude, just not paying attention. Corpus callosum. So this is like the region of the brain that connects both sides of the cerebral hemispheres. And it comes from tough body. Lots of different tracts are going to go through here. So these are going to be myelinated fibers. This is the coolest thing about the corpus callosum is I think it was like 20 some years ago, they started to do corpus callostomies. And so if a person has grand mal seizures, so this is for patients with generalized type seizures, right? Both sides of the brain. Usually it starts with like one little spot. It starts firing like crazy, and then that spot contagious, right? It goes all across the entire brain. And if a patient does not respond to anti-epileptic meds, so if they have refractory seizures, it's not responsive to drugs, surgeons can go in there and they can cut the corpus callosum. That's called a corpus callostomy. And it is so interesting because both sides of the brain will have different personalities. There's a Radiolab episode that I was listening to that talked about this procedure. And the patients that get this done, they can actually function normal after they get the procedure done. It's pretty incredible. But what happens is they have two personalities on both sides of their body. So this lady was talking about how she would be getting dressed in the morning. So she would get like a blouse off the rack, and then she would start putting the shirt on. And her other hand would take the shirt off and put it back on the rack because the other side of the body didn't want to wear that shirt. And so, yeah, different personalities for different sides of the brain. So super interesting. But this is one treatment method that you could do if you cannot treat the seizures, right? So this is kind of like a last resort, procedure of last resort. But super interesting. In other words, you're going to isolate the seizures to just one side once you sever the corpus callosum. All right, things that you do and things that you don't do. So things to do. If the person is seizing in front of you, you want to lay them down. You want to tilt them over to the side. Tell their service dog to do the same thing. If they have a service dog, tilt them over to the side. Make sure there's nothing sharp around them, right? Because they can hurt themselves very easily. Make sure to protect their head, right? Because they're going to be banging around with tonic-clonic seizures. If they have glasses, take off the glasses, prevent damage. If they're wearing a necktie, loosen up the necktie. Do not hold the person down. It's a bad idea. Don't put anything in their mouth. That's a really bad idea. Don't give mouth-to-mouth CPR with them. That's a bad idea. Don't give them water or food. That's another bad idea, right? Because they can choke. So they're pretty obvious. Pretty obvious things that you want to do and don't do. All right. Any questions on seizures? Cool. All right. Let's talk a little bit about headaches. Headaches. There's a few headaches that are really. Some are worse than others, right? There are some that are really bad. So cluster headaches, really bad. Sinus headaches, not terrible, just kind of uncomfortable. Tension headaches, kind of annoying. I get them at the end of the day, usually at the end of my afternoon patho lecture at 4:45 because of my glasses, I have a throbbing headache, like all around my head. I get that like almost every single day. I should wear my contacts more often. But my contacts make my eyes dry, so I don't know. It's a double-edged sword, right? Or I should get LASIK surgery. That'd be kind of... Migraines. We'll talk about migraines later. But these are all the headaches, right? You get the migraine headache, you get the hypertension headache, stress headache, and this is the headache I get after I'm done teaching all day. All right, types of headaches. So the tension headache is going to be the most common type of headache. Stress headache, pericranial myofascial pain, if you want to be a total nerd about it. Incidence rate, it happens quite often, right? And it usually happens multiple times a month. It usually resolves after a few hours, especially if you take like ibuprofen or something. It can be mild to moderate. Constant pain bilateral. So it's going to be both sides of the head, and it's going to feel like you're wearing a really tight like sweatband, right? If you're wearing a really tight sweatband around your head, that's kind of like the regions that are affected. For me, it's usually right where my glasses are, right where the arms of the glasses tighten around the back, right above my ears, or posterior and above my ears. Like right here is where I get it. You can take NSAIDs, Tylenol, aspirin. If it's really bad, you could take tricyclics. Botox injections are really interesting. You can do Botox injections for migraines too. So you would do that periodically because Botox injections, they cause paralysis of the muscles, right? Botulinum toxin. Is botulinum toxin the most toxic thing known to man? It's actually the most dangerous toxin known to man. Like it takes a little bit of botulinum toxin to kill you. But the cosmetic industry has capitalized immensely on Botox, right? I worked at a med spa for a while, and the amount of money that they make from Botox injections is stupid. It makes so much money. So if any of you want to like run a med spa in the future, you'd be making bank, right? Because guess what? When people get older, they get wrinkly, right? And Botox only works for about 6 months, so then you get repeat customers, right? So it's a good thing for that. Same thing with headaches. If you get Botox injections to paralyze those muscles, you'll get that periodically. It's like every 6 months. I think insurance covers this sometimes, right? If you get migraines that don't really respond to meds, I believe insurance covers it. If you take Botox for the arms, though, like, are you guys familiar with hyperhidrosis? Yeah, that's like sweaty armpits. You can get Botox injections for sweaty armpits. It lasts like 6 months. When I worked at the med spa, I actually got that done. It was awesome. I didn't have to wear anything. I didn't wear deodorant for like almost a year. And then I started sweating again. But insurance does not cover that. And that's a really expensive procedure. It's like $1,000. I didn't pay $1. I got it for free. But if you went in there to get treatment for hyperhidrosis, you'd be paying $1,000 for that treatment. It's really expensive. But anyways, that's my serious digression. So tension headaches, muscle tension, right? So stress, muscle tension. If you're scrunching up your shoulders a lot, that can also affect the muscles on your head too. So you can get tension headaches from that. Bad posture, inflammation, stress, anxiety. If you're angry all the time, wearing glasses for sure. I can testify on that behalf. Abnormalities can also cause that too. So if you have misaligned jaws or teeth. All right, any questions on tension headaches? Those are the easiest ones to diagnose. Cluster headaches, this one's sad. Cluster headaches, they feel like you're getting an ice pick jamming into your eye. They feel really painful. They're also called suicide headaches. Some people commit suicide because these are so freaking painful. They're also called suicide headaches because sometimes people just bash their head against the wall to try to get the pain to stop. That's how bad the pain is. And they're really difficult to treat. Sometimes you have to try to administer a lot of oxygen to try to like give them a lot more oxygen. Sometimes you have to give them drugs like serotonergic type drugs, so 5-HT drugs. So sumatriptan would be something that you could possibly use for this. There's also been more studies now. Where's that? I didn't put it in here, but there's other studies that have been coming out lately on other serotonergic compounds, like psilocybin, for example. There's been studies done on LSD for treatment of cluster headaches, which I guess like tripping for 14 hours would be better than getting a cluster headache. So I don't know. But anyways, let's watch a little video on suicide headaches here.
The following report contains some disturbing images.
It is one of the most painful experiences that a human can endure.
It feels as though somebody is rubbing your inside of your face and pulling as far out and as far wide as they can.
Difficult to watch, often unbearable to experience. The pain of a cluster headache can be indescribable. Some sufferers post videos showing an attack to try and convey the reality. We're using these with their permission. Scott has suffered them for 10 years. He helps run a support group, Ouch UK.
I have knocked myself out on various occasions because of the pain, and I will find something very, very hard to strike my against them. Because you're driven, it's a primeval driver to stop the pain.
Cluster headaches baffle doctors. Far more intense than a migraine. Many sufferers, like Rachel, experience them when seasons change.
But I will get my whispering in every autumn without fail.
Rachel's volunteered for a new research project taking place at King's College Hospital in South London.
So we're looking to see what happens in the brain during the attacks compared to when there is no attack.
Around 40 sufferers will have their brains scanned.
This is the posterior hypothalamus, and it's also known as the internal body clock. We think that is linked with the cluster headache. They tend to have more cluster attacks around spring and autumn. We don't quite understand the reason behind that.
This will be an ambitious, at times arduous project. Volunteers will also be having their brains scanned whilst an attack is taking place.
Unless people put themselves forward to things like this, we never going to know any more about cluster headache.
It's estimated there are around 130,000 sufferers in the UK, possibly more as the condition is often misdiagnosed. This patient, who's asked to remain anonymous, is being injected with steroids and an anaesthetic. A preventative measure that can help, but is only effective for a few weeks.
To dumb down the activity of the nerves, hence give some relief to these patients.
If so, this device, which would be implanted inside a patient's head, could offer long-term help.
The way it does is by delivering some electricity around the nerve and damping down the hyperactivity, the excessive activation of the nerves, which is firing without any control.
Trials are going well. The team at Guy's and St Thomas's Hospital hope to make it available within a year, a long-awaited step forward for sufferers of this distressing condition. Tim Butlers, BBC News.
Not to give you a migraine. British, my God. Anyways, so unilateral, and it's going to be behind the eye. That's usually kind of where it's happening. You're going to get like tearing, right, crying, runny nose, eyelids swelling, drooping. Those are some of the major symptoms of a cluster headache. No, trigeminal neuralgia is different. So trigeminal neuralgia is going to be like really painful sensations on the face, right? Cluster headaches, they don't really know what caused it. It's more common in men. Trigeminal neuralgia is actually more common in women. And it's usually going to be linked to MS, multiple sclerosis. And so you get demyelination of the trigeminal nerve. A breeze of wind can trigger trigeminal neuralgia. And that also can be so painful that some people have actually committed suicide because of it. It is. It's one of the most painful nerve disorders out there. So yeah, that's a great question. But it's not related to cluster headaches, at least to my knowledge. So yeah, they cluster around the eyes, and then they cluster for up to 8 times, right? 8 attacks a day. And they last minutes to hours, and it is the suicide headache. Right? So that's the main thing about cluster headaches. So we have 5 more minutes left. Let's go into migraines, as the British say. So migraine headaches, those are going to be due to vasospasms. So vasodilation, vasospasms. And so because of that, you're going to get changes in blood flow to the brain. That's why you can see the auras affecting like the occipital lobe, for example. You might get blind spots, right? So that could be one of the things that you see as an aura. And it's mostly going to be unilateral. It could be bilateral too, but it's going to be really painful. Very common in women, especially during menstruation cycles. So my wife gets these. My wife gets migraines. She's been prescribed sumatriptan. So she takes that as a way to relieve the pain. Yeah. So, and they last a while. They can last up to days. Signs and symptoms, nausea and vomiting. So when I had my first migraine, that's one of the things. Once I started actually feeling the pain, I felt so nauseous. I had to lay down. You get photophobia. You don't want to see light. So I had to like lay down in a quiet room, took a bunch of NSAIDs to try to stop the pain. So you get photophobia. You can get tired. You can also get phonophobia. You don't want to hear loud noises. And then sometimes they can be preceded by an aura. So auras can be a bunch of things. It can be hallucinations, right? So changes in sight. So when I would get blind spots, because you know how your brain kind of fills in empty spots. You know how you have the natural blind spot? Same thing that happens with like the face. If I would look at someone's face, I wouldn't see their mouth. I would just see their eyes. Or sometimes I wouldn't see their eye. And so you would see blind spots. This happened to me while I was driving once. Freaked me out. I had to like pull over and lay down for a little bit until like it subsided. So it can be really scary. So you can get visual changes. You could potentially, if bad enough, get paresthesias, shimmering spots, flashing lights, zigzags. So these are like visual scotomas. And then drugs that you can take to treat this. Sumatriptan is a really great example of a drug that's commonly used for migraines. It's a 5-HT agonist, so that's the serotonergic receptors. And you can also take drugs that have caffeine in them, because caffeine, what does caffeine do to your blood vessels? Yeah, so it can help to vasoconstrict your blood vessels. And a lot of headache meds are going to come with caffeine. So they can like reduce blood flow to certain areas, because if you get too much vasodilation, that can cause headache as well. So vasodilation can be one of those things. What's up? From a trauma? Oh, yeah, totally. I mean, I definitely, you can get headache from trauma. So, yeah, it is very similar. Yeah, I mean, migraine, the underlying mechanism is like vasoconstriction, vasodilation. So I'd imagine that trauma would cause that to happen, especially if your brain is undergoing repair, which is kind of what's happening during concussions. Your brain is trying to repair itself and heal. And so I'd imagine that there'd be alterations in blood flow as well. So let's continue on over here next week with migraine. So we'll revisit migraine again. And have a wonderful weekend.